Laparoscopic adrenalectomy has become the standard technique for the surgical removal of the adrenal gland at many centers worldwide. Functional adrenal tumors such as aldosteronoma, glucocorticoid, androgen/estrogen producing adenomas, and small to moderate-sized solitary pheochromocytomas are amenable to removal via a laparoscopic approach. The advantages of laparoscopic adrenalectomy over open adrenalectomy are well documented and include a shorter hospital stay, a decrease in postoperative pain, shorter interval between surgery and return to preoperative activity level, and improved cosmesis. Various laparoscopic approaches to the adrenal gland have been described. Among these are the lateral transabdominal, anterior transabdominal, lateral retroperitoneal, and posterior retroperitoneal approaches. Each of these methods has specific advantages and disadvantages. This article reviews the transperitoneal approach to laparoscopic adrenalectomy, and discusses indications, operative technique, and a survey of the available literature. Indications: laparoscopic adrenalectomy, LA, is currently considered the preferred alternative to open adrenalectomy for the vast majority of patients with small and medium-sized benign functioning and non-functioning adrenal lesions, Table 39.2.1. The available data indicate that the largest experience has been with aldosteronomas followed by Cushing's syndrome, non-functioning adrenal masses, incidental-OMAS, pheochromocytoma, and Cushing's disease. Other non-prevalent reported indications included myelolipoma, cysts, adrenal hemorrhage, androgen-secreting tumors, and ganglioneromas. Laparoscopic adrenalectomy has been successfully performed in several other conditions, including the following, but further experience is still required before the procedure can be used routinely. Neuroblastoma congenital adrenal hyperplasia, CAH, in children isolated adrenal metastases masses larger than 10 to 12 cm. Contraindications to laparoscopic adrenalectomy include the following: large invasive adrenocortical carcinoma, although limited experience with non-invasive malignant tumors yielded encouraging results, an initial laparoscopic approach is an acceptable option. Only in experienced hands at selected specialized centers. Metastatic pheochromocytoma to aortic nodes, untreated/uncorrectable coagulopathy. Other contraindications for general anesthesia and laparoscopy. Operative approaches. Several laparoscopic approaches to the adrenal glands are recognized: lateral transabdominal with the patient in the lateral decubitus positio, anterior transabdominal with the patient in the supine position, retroperitoneal endoscopic adrenalectomy, lateral or posterior. Functional adrenal cortical masses. Cushing's syndrome caused by benign cortisol-producing adenoma. Cushing's disease after failed pituitary surgery, or after failure to control or to find an ectopic tumor producing adrenocorticotropic hormone aldosterone-producing adenoma. Conn syndrome, rare virilizing/feminizing secreting tumors. Functional adrenal medullary masses. Benign adrenal pheochromocytoma, lipoma, and hemorrhage. Non-functional adrenal masses. Benign-looking incidentalomas, non-functioning adenomas, confined to the adrenal glands and meeting accepted criteria for adrenalectomy, size greater than 4 cm at presentation or growth in follow-up. Benign symptomatic lesions. Rare entities such as cyst, myelolipoma, and hemorrhage. Although no clear objective advantages of one surgical approach over the others have been conclusively shown, the lateral transabdominal approach is the preferred technique practiced by most surgeons, followed by the retroperitoneal approach. The lateral transabdominal approach to the left adrenal gland will be described first, followed by the approach to the right adrenal. Patient position and room setup. Place the patient in the left lateral decubitus position with the left side up, Fig. 1. Position a cushion under the right flank and a protective roll under the right axilla. The left arm is extended over a board and secured. The right arm is positioned parallel to the left, suspended on a board and secured. Flex the table to maximize the distance between the costal margin and the iliac crest, and secure the patient's torso and legs to the table within cloth tape. The surgical prep should extend from the nipple to the anterior superior iliac spine, and from the midline anteriorly to the spine posteriorly. The surgeon and the first assistant stand facing the patient's abdomen. Place 2 monitors near the head of the table. Trocar placement and choice of laparoscope. Although closed technique with verus needle is possible, we prefer the open technique to access the abdomen and establish pneumoperitoneum. This is done at the left anterior axillary line, approximately 2 cm below and parallel to the costal margin. Insufflate to 15 mm Hg and place a 10 mm trocar at the verus insertion point. Insert a 10 mm 30-degree laparoscope through this port. Place the second 10 mm trocar under the 11th rib at the mid-axillary line. Place the third 10 mm trocar more medial and anterior to the first trocar. Position this trocar along the midclavicular line, lateral to the rectus muscle. A fourth trocar, 5 mm, may be inserted dorsally at the costovertebral angle to retract the spleen. This port is usually not necessary in patients with normal size spleens. The trocars should be at least 5 cm or, more optimally, 10 cm away from each other. Place the laparoscope through the anterior-most trocar with the two middle trocars as the surgeon's operating ports. Left adrenalectomy working with laparoscopic dissector and scissors. Mobilize the splenic flexure medially to expose the lenorenal ligament. Incise the lenorenal ligament infero-superiorly approximately 1 cm from the spleen. Stop the dissection when the short gastric vessels are visualized posteriorly behind the stomach. This maneuver allows the spleen to fall medially, exposing the retroperitoneal space. If necessary, retract the spleen gently with an atraumatic retractor pass through the most posterior, fourth, trocar. Laparoscopic ultrasound may be used as an adjunct to identify the adrenal gland, the mass within the gland, and the adrenal vein grasping the paranephric fat. Dissect the lateral and anterior part of the adrenal gland. Hook electrocautery or ultrasonic scalpel are useful instruments for this phase of the dissection. Avoid grasping the adrenal gland or tumor directly, as the fragile tissue is likely to tear. Sometimes it is possible to grasp the connective tissue around the tumor or adrenal gland. At certain points, tilt the table to the reverse Trendelenburg position. For smaller adrenals, less than 5 cm, dissect the adrenal gland inferomedially. The adrenal vein may be identified early in the dissection, dissected using a right-angle instrument, and clipped with medium to large titanium clips, using 3 clips proximally and 2 clips distally. Continue the dissection supraradially, clipping adrenal branches of the inferior phrenic vessels.
For larger glands and GT, 5 cm, dissect the adrenal gland superiorly, clipping the adrenal branches of the inferior phrenic vessels. Clip and divide the adrenal vein. Last J. Place the adrenal gland in an appropriately sized impermeable nylon bag. Remove the bag through the original trocar site by using a Kelly clamp to spread the abdominal wall musculature. The abdominal incision may have to be enlarged to remove the specimen. Right adrenalectomy. A. Patient position and room setup are the reverse of those described for the left adrenal. B. Trocar placement and choice of laparoscope. I. Access is gained using the open technique at the right anterior axillary line, approximately 2 cm below and parallel to the costal margin. Palpate the liver carefully to avoid the edge of the liver. Place a 10 mm trocar for the 30-degree angled laparoscope at this site. E. Place 3 additional 10 mm trocars 2 cm below and parallel to the subcostal margin. Position 1 trocar in the right flank, inferior and posterior to the tip of the 11th rib, and the other 2 more anterior and medial. The most medial trocar should be lateral to the edge of the ipsilateral rectus muscle. The trocars should be at least 5 cm or, more optimally, 10 cm away from each other. The 2 most lateral trocars are the surgeon's operating ports. The most anterior port is used to place the fan retractor to retract the right lobe of the liver anteriorly. Performing the adrenalectomy, the surgeon works with the laparoscopic dissector and scissors passed through the 2 most lateral ports. Insert the fan retractor along the most anterior port and retract the right hepatic lobe anteriorly. Lyse the right lateral hepatic attachments and the right triangular ligament up to the diaphragm. Laparoscopic ultrasound may be of assistance in identifying the anatomy. Identify the inferolateral edge of the right adrenal gland and dissect inferiorly. Tilt the table to the reverse Trendelenburg position. For adrenal glands less than 5 cm in diameter, the right adrenal vein can be visualized early in the operation. Identify the right renal vein in the inferior-most margin of the dissection. Along the lateral edge of the vena cava, the right adrenal vein is encountered and isolated using a right-angle instrument. Secure the vein proximally with 3 titanium clips and distally with 2 clips before transection. Clip and divide the adrenal branches of the inferior phrenic vein as the dissection proceeds superiorly for adrenal glands greater than 5 cm. Perform the lateral and superior dissection first, then dissect caudally along the transect the vein as previously described. A short fat right adrenal vein may require the vascular endoscopic stapler for secure division. Convert one of the 10 trocars to a 12 trocar and carefully pass the stapler, taking great care not to tear the vein. Place the adrenal gland in an impermeable nylon bag and removed via the original trocar.